Broadcasting. Webinars now broadcasting. I think that we should everybody should hear us now, and welcome to Walking in Your Dental Sleep. Hope everyone's having a good Tuesday evening after a long weekend. Rich, did you go fishing or anything this weekend? I haven't even talked to you.
Who, me? Go fishing?
Yeah, you don't fish.
I haven't been since yesterday, but yeah, had a good time. So hopefully everybody had a safe weekend and you're staying healthy, and we appreciate you guys joining us tonight.
Absolutely. We're going to talk about why you should be involved in dental sleep. Are you just kind of going through your practice and not realizing this is a whole nother part of your practice you could be tapping into? And just to see if people are awake after the long weekend, I thought we would start off with a poll and just see how many of you screen all of your adult patients for oral cancer. And so you all should be able to see that, and no one knows which answer, not a right or wrong answer, but let everybody put that up there, and we got an oral cancer slide for a second. And I think we're going to have a real big point. If you'll stay till the end, I think probably the very end of this, if you'll pay attention, it'll be impact maybe the rest of your lives if you pay attention here and listen to what we have to say and then go out and implement it. So I'm going to end the poll here and share with you all. It looks like the vast majority of you are doing that, 79% or 76% or greater. There's a few of you down at 13%, but I'd say the majority of you is over 50% for sure, up to over 80%, which makes sense. That's what we were taught to do in school. And we could do polls all day. I'm not going to bore you with doing a ton of them. We'll do one at the end, again, as I mentioned. But if I asked you how many you all found of oral cancer last year, Rich and I do a lot of courses. I was thinking about this, Rich. I've stood in front of at least 10,000 dentists and team members over the last 10, 15 years when you think of all the lectures we do. And most of the time I ask this question: how many people did you find with oral cancer last year? I've asked that a lot of people. The most I've ever heard in a group or any other people I've done was 6. One person found 6 patients with oral cancer. And the reason is, I mean, that's 1 in 1,000. So if you got 1,000 adult patients, you know, most people are finding 1 or so a year in there. It's our job to do that. But I want to know how many, and this is changing. We're going to ask you a similar question here. I'm going to stop sharing the results. I'm going to ask you the same question about obstructive sleep apnea. So hit here, hit launch. How many of you are doing the same thing for all your adult patients? Because this is useful for Rich and I to understand where everybody is on the subject. I'll give you a second to do that. And we're going to talk about your role in doing this going forward. And should we be doing this? Is it part of our job to do? We've got a similar number of attendees, so I'm not going to waste too much more time here. And I'll share the results with you. And you can see we have kind of the opposite there. The majority of the people is less than 25%, certainly less than 50. And that's this 41's higher than probably we would have gotten a few years ago. And I think if you'll pay attention and really embrace what we have to talk about, it could literally change your life. And not just change your life, it could change your patients' lives, because 1 in 1,000 adults has oral cancer. 1 in 5, pushing 1 in 4 adults has obstructive sleep apnea. And if you really want to help your patients and impact their lives, there's so much more need in this area. And we have to think about, is this just as important for us to be doing as a dentist? So just food for thought. Rich, you know, I just realized I don't know that I have our introduction slides on here. I put this together over the long weekend. I may not have that in there. And if I don't, I'm Guy Yatros, my good friend and partner, Rich Drake, there on the other end. We've been doing this for 20 years independently, jointly over 40 years of dental sleep experience. And we hope to help you all learn to do this in your practice. We're both dentists that just do this all the time and help other dentists how to do this. So, Rich, do you know why I have this slide up here?
How do you get rid of the poll? I'm having trouble seeing the slides myself.
You should be able just to close yours
and just close
on your end. Yeah. And if anybody else, thanks for asking. If anybody else has a similar thing, did it close?
So the question is, why do you have this slide up there?
Yeah, you talk to a lot of doctors every day. I know that that's one of your deals. You probably spend more time talking to physicians. Does this slide mean anything to you? Because I don't even know that we've discussed why I put this slide in here.
Well, I can tell you today, Guy, I talked to a physician and he said, man, I had no idea that as a dentist you could even do this. Yeah. I mean, those were the words out of his mouth. So
Yeah.
I don't know. We're certainly hoping to tip the scales, here when you look at that. I often think, Guy, if you and I had been there in the early 80s when John Remmers was sticking vacuum cleaner hoses up people's noses, trying to keep their airways from closing down. If you and I had been there and you said, "Hey, Rich, what if we just grab that guy's jaw and we move it out?" I think we'd have 95% of the market share, and people would be going, "What in the world do you want to put that mask on for?" So I think part of this goes all the way back to when we were educated. We had oral cancer, drilled into our psyche, from day one in dental school, and physicians have CPAP. And it just takes time, and it takes a lot of dentists out there, and it takes a lot of patience, and trying to tip the scale, so to speak. But it's certainly easier now, Guy, than it was 20 years ago when we started.
It absolutely is. And I think that if you learn about this, you can help tilt the scale, because most people today get CPAP given to them with really no other options if they're diagnosed with apnea. But it's changing, and we can affect this, because if you ask which one works better, I can tell you in today's world, we know they're about even. That's not just Guy's opinion. We can share information on that. The new practice parameters by the American Academy of Sleep Medicine state that. And so this is a changing target. And if we change this even a little bit, think of all the patients that can be helped with dental devices. When 24 million, I think we have coming up in a little bit that have this problem. And this is important. I mean, dentistry is important. We're both dentists. We agree that teeth are important. We're taught to save teeth, but this is about living and breathing. And here's two examples of where CPAP failed people. They were both of these famous people, Judge Scalia and Carrie Fisher, died. And right out of the paper, it states that they felt it had to do with, well, at least Carrie Fisher had to do with her apnea. And then Judge Scalia, his CPAP wasn't hooked up. So it was, not effective. And this is a shame. When we know what causes this problem, educated, wealthy people, this is affecting. And by the way, if you have any questions, put them in the question box. We'll get to all of them before the night's over. So you can use the chat as well, but the question box really will go to answer the questions. And Rich, I know you have a lot of stories, but since I put the slides together, I put my true story in. I know you have several of these stories yourself. This is Chief Saunders, and he was a gentleman that someone introduced me to that I ran into the gym all the time. He would just say, "Hey, Chief." I'd say, "Hey, Chief." He'd say, "Hey, Doc." And one day he came up to me and said, "Hey, Doc, I can't wear my CPAP. I hear you do that. Can I come in and see you?" And I gave him a card and said, "Sure, come in and see me." But he never came in, because within a week or so after that, we're reading the paper and we found out, he died. And right in the paper, it stated that, he'd had surgery for his apnea. He was struggling with his apnea. Felt apnea had something to do with him passing away in the early 50s. He was a fit guy. And so this is important. When what we're going to be talking about tonight, we call this dental sleep medicine. And I almost wish, Rich, that we'd never put the sleep in it, because it is about sleeping, and that's important. But what we're really talking about is breathing. That's what these patients aren't doing at night. And when you go to your patients and you say, "Hey, you may not be sleeping well," no one sleeps well, I don't need sleep. Ask them if they need to breathe. Is breathing overrated? Is that something you could do without? Is this important to you? And the people look at you, I don't think breathing's overrated. I think most people don't say, I can live without breathing. I don't need sleep, they'll say, but they're not going to say that about breathing. And I can tell you, these two people here, you had two choices. You could give them a pot of gold right now, Rich. What do you think they would take instead? Went the wrong way on my slides there. Or some oxygen or air.
A breath.
Take a breath. You get all of Bezos's money there in the one pile, or this regulator, and that's what you're going to take, because that's our most important thing that we do as humans. It's the number one thing that our bodies have to do, and we'll do anything to do it. And at night, these patients, strangely enough, aren't breathing, and they don't know they're not breathing, and no one's telling them they're not breathing. For periods of time, Rich, you and I look at the sleep studies, you'll see people go 30 seconds, sometimes a minute, with really decreased breathing or not breathing at all. And no one is talking to these patients, because 90% of the patients, 85 at best, even know this is a problem. And that's why we need to be doing this as dentists. And Rich, I think this that came out from the ADA a few years ago made our job easier, because we've been saying this for a long time that dentists should be doing this. And the ADA's position here is that, yeah, dentists are in the best position, or at least a good position, to be talking to their patients about airway problems. It's as much our jobs to be looking for that as it is to be talking to them about oral cancer or periodontal disease or anything else. And I think once we get to that point, it becomes easier.
Yeah, and most dentists aren't even aware that this is the ADA's position. So, the ADA put this out, over 3 years ago, so 18, 19, 20, almost 3 years ago. And so we need to be more diligent about that. If you guys are on here tonight and you're listening to this, well, that's the first step, so we're just going to try to, we can't talk about everything you want to learn about tonight. We could take literally every single one of these slides, and we could probably talk about it for 2 or 3 hours. So we want this to be, an introductory type thing. But even if you've been doing this for a while, stick around, because we promise you'll pick up a few pearls here and there.
Yeah, and I think since the ADA said this, we're going to go through each of those steps, and as Rich talked about, and we can elaborate on them at a later date. But I hope when you leave here, you're going to see what your position is. And we call this walking in your dental sleep. I mean, you're just walking into your practice, and there's all this dental sleep, this airway problem that's happening. It's affecting your dentistry. It's affecting your patients' lives. And the ADA says it's our job to be talking to these patients about it. And then if we want to treat them with a dental device, well, dentists are the people who should be doing this, and we should be able to follow them up. And so, your job is to save teeth. Let's be clear on that. But it's also to take into consideration your patient's well-being and what's best for them. And we talk to our patients about cessation of smoking, I think, don't we? Because it affects the gums, it affects their lives. It's our job they're in our office and we see stain on their teeth and we think they smoke. We say, this is not good for you. Well, we're going to talk about how bad apnea is in comparison to smoking in just a few moments. But if that's our job, surely this is too. And I can tell you what, you don't have to decide about this. We could talk for hours about how airway can affect your restorative practices too, because there is a component to this that we don't have time to get in today, but I'll just put the teaser out there. We come to one of our other courses, or we'll maybe do a whole hour on this someday. But I am totally convinced, as well as most people, that there's at least some component to bruxism and airway in some patients, if not a lot of patients. And if we can figure that out, maybe our restorative practices will be better off as well. So I see you answered a question there, Rich. Keep the questions coming up.
Well, I like to say, Guy, when I consult with patients, every night you go to sleep and you need sleep, you got to rest, you restore, all these things. We talk about that for hours too. And when your airway closes down, your brain has to make a choice. Do you want oxygen or do you want sleep? And you need both, but oxygen usually wins. If you're alive and you're sitting here talking to me, then oxygen has won every time so far. But it doesn't always win. A lot of people go to sleep and they never wake up. So it's sad. Your story. I've heard your story about the chief. I didn't even know the guy, but that's just a sad story, and it doesn't have to be that way. I would tell you, don't wait until something like that happens in your own life to say, wow, I should have listened to those guys. I should have done something. This is where you really seriously can impact a very large number of lives in your practice and in your community. And it's all good.
And, we don't all have to do this. I think you'll find out you want to, most of you, but you don't. But at the very least, if you should leave this webinar thinking about it being your job to start looking at your patients and having discussions about their airway. And if it's not, if you don't want to be involved with the treatment, that's fine. You'd rather do root canals, crowns, whatever you love doing in your practice, fine. But you're going to need to be involved in the airway. So there's the slide. I thought maybe I forgot to put it in. We already had our introduction. So there's better pictures of Rich and I than probably you're seeing right now. So we've been doing this a long time. And at the end, if you want to know how we can help you more, we'll talk a little bit about what we do. So the American Academy of Sleep Medicine. So that's the physicians group where they look at at treating the patients from narcolepsy to obstructive sleep apnea. And so when it comes to obstructive sleep apnea, they have standards of what the standard of care should be. And in 2006, that changed, and it changed for really to include dentists as crucial caregivers for patients who are diagnosed with obstructive sleep apnea. So this is not new. I think a lot of people think dental sleep's new, Rich. When I talk to people, oh, this is a new growing area. It's not new. We're just finally coming into our own. And yeah, it's taken 14 years for this to really start getting traction. I mean, the new practice parameters are even more in the dentist's favors. But do you remember when this came out, how excited we were? Like, finally.
And still nothing changed, certainly overnight. I think when we talk about, raising our kids and teaching our kids to be patient, I think that's the hardest thing that Guy and I have dealt with in a lot of ways, is that we want this to change because we know what we can do for patients. And yet most dentists have been very reluctant to this. And again, I think that goes back to education, Guy. If we don't learn about it in dental school and it doesn't seem important, then we don't do it. So we're finally starting to see that change. A lot of the new graduates have had a few hours, or they've taken an internship, or they've done something with sleep. So, but we talk about this as the day the earth shook, so, we all go back, like you said, 14 years, and we were finally recognized by an authority in this that said, hey, if people for mild to moderate sleep apnea, we can give them a dental device. If they have severe, they should use CPAP first. And we certainly use that, Guy, over the last decade in a lot of our conversations with physicians as we had that, because they still didn't know about it. And there's still physicians out there who don't know about this.
It's why we started off with a scale, and we can fix it. And I'm gonna pause that for just a second. And here's why why we should be fixing this. And I think as we show you this video of someone having apnea, understand that 85% of the time the patients do not know they have this problem. So it's not something that they're aware of. Just like bruxism, your patients come in and say, oh, I grind my teeth. Most of them don't know it. Most of the patients don't know they do this. And I see a question here, does this affect hypertension, blood pressure? Well, just imagine what this is doing to this patient's body cardiovascularly as we go through this. And you can see he's snoring. I want to emphasize snoring's not good, because he's still not getting good air through there, is he? That snoring's, something's amok there, right? Barely air. So now he quit breathing. Why? He has a cork in his throat. Look at this. You think his heart rate's up for the question about the hypertension? You think his blood pressure's spiking? His heart rate's beating. What's going to keep him from dying? Because Richie didn't trick me. He's not going to die, is he? No, he's not died yet.
I hope not.
He's not going to die. Something's going to happen here. Oh, he made that choice, right? He chose to breathe instead of sleeping there. Okay. And do you think he's going to feel rested tomorrow? You think he may have a headache?
He's going to feel just like he did every other day, Guy. So sometimes people don't know the difference. They don't, we know, because we give people a dental device and they go, oh my God, I had no idea I was that tired, or whatever, because they don't know any different. And like you said, unless you sleep with a bed partner who complains or, wants to talk about that, or, a lot of guys say, man, my wife never said anything, but I went to the hunting cabin and they almost shot me, last weekend. Because I snored so bad. So again, we're just in a great position. A lot of people come get their teeth cleaned once or twice a year, and we're in a fantastic position to bring this up.
Yeah, I'll tell a real quick story on that. My sister, I just made her a dental device recently, just about a month or so ago. And she just her husband was saying she was snoring, and we tested her and she only had mild apnea. I think, well, does mild apnea make a difference? And my sister's not usually great to compliment me on anything, but to be honest with you, she sent me a text 2 nights ago. I can't believe how well I'm sleeping. True story. And she said, I just feel so much better. And she didn't think she had a problem sleeping. and now she feels better in the morning already just from wearing this device for 6 weeks or so. And so we could spend an hour talking about the OSA pathology here a little bit, but let's just kind of dumb it down for you. It isn't that difficult. You go to sleep, what happens? Well, you get relaxed. Your muscles start relaxing, and what happens when that happens? Your airway narrows. Because your muscles relax, the airway becomes smaller, and that's what causes the snoring. The snoring isn't just the flabbiness. It's because the airway is smaller, and then oftentimes, most of the time, the air is moving faster. Because as you narrow the airway, the velocity of the air goes, but less air moves. And so what I want to emphasize is snoring is not good. When your patients go, "Oh, I just snore," that means they have
it's always a joke or a laugh. Yeah.
And it's not a laughing matter, because snoring means you have a problem. And you can use that to at least educate them. That snoring means there is an issue there, and eventually it might narrow to the point where they quit breathing. That's what an apnea is. And then they became hypoxic. And then here's that choice Rich is talking about. The patient had to choose between breathing and sleeping. So he's in deep sleep. He's like, well, I've got to breathe. And so what happens? One of the questions that came in, do they always wake up? The answer is no. Most of the time they do, though. And this patient chose to breathe. So what happened? He had an arousal from sleep. So he goes from deep sleep to lighter sleep. He has some muscle contraction. His muscles opened up the airway. He breathed real deep again. And then what happened? He went right back into that cycle again, because, of course, he's sleepy, even though he may not know that. And it's just a big circle that we get in. And I think this slide, I really thank my good friend Alan Moses for providing this to me many years ago. I hope he's doing well in his retirement. But this, I always ask people, is this tongue part of what we have to deal with every day? If that tongue has oral cancer on it, is that our job to tell the patient, hey, you may have oral cancer on your tongue? Is that our job? And I ask, when the tongue does this at night, is that our job to be talking to patients about the possibility that may be happening at night? I even like to back that up just to show you again, because I think it's that important. If you can get this through your minds and say, look, this is my job to do this, because it's quiet. It's not quiet and have snoring, but you can't see this. It's like periodontal disease. The patient just has to trust in you that something's going on there, because you can't show them this so easily. It's not like showing a broken tooth, and you've got to be comfortable with discussing something that is something we need to be talking about, even though I can't show you a picture of it here on that particular patient. And that's, once you get that comfortable with that, then you can talk to your patients about getting tested. Rich, today, when did the last practice parameters came out? 2015, right? And I think what changed on that from the 2006 ones we just showed you, I didn't put a slide in, but we can tell you, basically it says that because of compliance, as high as 83% of the patients don't wear their CPAP effectively, is what it said in the practice parameters from American Academy of Sleep Medicine, that the mean disease alleviation calculation, so how much the treatment decreases the apneic load on these patients, dental devices and CPAP may be equal. And basically, that's where they came up with it. If someone doesn't want a CPAP or prefer an alternative treatment, that's the two treatments for obstructive sleep apnea on the screen. That's it. That's the first line of therapy. If someone gets diagnosed with apnea, that's the two choices. There are other things you can do if these fail or don't work or aren't indicated for some reason, but we don't go out and start doing surgery on patients or Inspire genoglossus implants.
Nerve stimulators, right.
Nerve stimulators and some cool things that we can do. This is the first line of therapy. This is the front lines here. And we're going to look at the number of people who have this. I think it's 24 million on one of the slides coming up here that have moderate to severe apnea. And these are the two choices. These adjunctive things we could talk about, but those two things on the screen are the two treatments. And dentists own one of them. I mean, what a financial opportunity. What an opportunity to be involved in something that can really help your patient. So we're going to talk about each of these for just a moment, and then we're going to talk about the steps to get dental sleep into your practice. But I think, Rich, if you had to guess, what percentage of patients, I don't think I've ever asked you this before, actually know what the CPAP does? They're wearing one. They're trying to wear it. They come in, Doc, Drake, I can't stand this thing. I try it. I'm not wearing it. I got the CPAC, they usually call it. That's because they pack it around with them. I don't know why they call it CPAC, but do you think most of them know how it works, or do they just
Yeah, I've heard all kinds of things from CPAC to CCRAP to all that stuff. So
once we can't talk about on the webinar too.
yeah,
yes.
but it's pressurizing your airway. And I don't think most people understand that. So if you put a CPAP mask on a balloon and held it there, depending on what that machine is set at, it's going to blow that balloon up so much, and then it's going to keep that balloon inflated at that particular pressure. It's not like a fan that's constantly blowing air in, but now you have to breathe out against that air that's coming in. So CPAP has saved a whole lot of lives, and we are not here to talk bad about CPAP in any way. It is an effective therapy if you can wear it most of the time. The challenge comes in, people can't wear it. So for the last 2 to 3 decades, all the physician says is, oh, you need to try harder. Oh, let's get a different mask. Oh, let's do this. Let's do that. I even have patients, they're really smart. So they got a 16-year-old, and the 16-year-old figures out how to lower their pressure. Well, now they can wear it. But now it's not helping them either, because it's not helping to keep their airway open. So you're too smart for your own good in that particular instance. But when you talk about the mean disease alleviation, Guy, and that comes from the dental device doesn't have to be as effective as the CPAP does. So CPAP can be effective, but again, you have to wear it. You also have to wear your dental device. And then we get into, okay, well, what's easier? What's high to do that? So we've talked about all of this stuff, and there are different types of masks. There are nasal pillows that just go in your nose. There's a nasal mask. There's a full face mask. There's different types of CPAP machines. There's an auto PAP that's supposed to be smart, and it senses what pressure you need. If you have 4 beers after the webinar tonight, Guy, you're going to need a higher CPAP pressure.
Right.
And that's part of what auto PAP does. And then we have BiPAP, and we have, different types of machines, and we don't need to go into all of that. But the point is that if a patient will wear it, most of the time it works. But you got to wear it.
You got to wear it. Got to wear it. And I think that's where dental devices come in. We could argue the compliance rates on CPAP. I think probably the most average people would say 30% long-term wear on those. Some people might say 50, but it's certainly nowhere near 80, 90, or 100. And dental devices, more people will wear them. That much is for sure. And so the overall effectiveness of the treatment is what Rich said. It's the efficacy of that treatment times the compliance. That's the formula there. I was in engineering for, I went to dental school. I love math, so got to put something into a formula here. And this demonstrates what Rich was talking about. If that CPAP works 100% of the time, which they don't always do, but they work quite well, but you only wear it half the time, this is where that mean disease alleviation calculation came from. We're at 50% overall treatment effectiveness. If you wear a dental device 70% of the 100% of the time, and it's 70% efficacy, well, we're at 70% overall treatment effectiveness. So each of these is important. The compliance and the efficacy are equally important in that equation that gives us the overall effectiveness of treatment. And I think that's why dental devices have now become equally accepted as a first line of therapy of treatment. Now, there's insurance and things we could talk about that can sway one way or another, and we can talk about that if you want to at a later date. But overall, these are both good treatments. And, right now, this hasn't changed. I think I've been using this slide for 10 years. And I keep thinking I'm going to change it, but then I like saying, you know what? I've been using this slide for 10 years, and it's not moved the needle a whole lot. That when you think about 100 people, 85% don't know they have it, so 15% at best we're treating, and half of those people aren't wearing their CPAP. This may be 5% now, Rich, but it's nowhere near 50% or something like that of the overall patients who have this. The vast majority of people who have this problem are undiagnosed and untreated. And do you think that we can help them? And furthermore, do you think there's a market for dental sleep? Here's the slide that we've been talking about. The 83% of the patients overall are non-adherent. This is from the 2015 findings for the American Academy of Sleep Medicine. And so I think when we look at 24 million Americans affected by this, globally. No, it's in the U.S. alone. I'm making sure I'm reading my slide right. And that's moderate I believe it's moderate to severe. Yeah, that's a huge number of people.
You can add, for up to mild, you can add another 50 million, so, and then globally, you're looking at 1 billion with a B. There's how many people on the planet now? Somewhere between 6 and 7 billion, I think, something like that.
Yeah, so it's a huge problem. And here's a statement that I say it's a really bold statement. And I'm not an absolute or bold statement kind of person, but this is a true statement. I had to change it a little bit because of COVID. But obstructive sleep apnea is our country's most significant chronic, untreated, undiagnosed medical disorder. So it's nothing that's this bad for you, that's this prevalent, that is so poorly treated in our country that's been around for this long. It's a huge problem, and we have an opportunity to fix it. And just to give you an idea of how bad this is, I'll go through this fairly quickly so we can make sure we get to the treatment stages. But this is the risk of having a heart attack. You take a standard person of 1 and you look at someone being overweight, it's 7 times. I think most people will go along with that. If you look at somebody who has hypertension, it's almost 8. Okay, 8 times more likely to have a heart attack if you have hypertension. What about smoking? We know it's terrible for you. We already talked about, we can talk with our patients about that. Well, that's pretty high, 11 times more likely to have a heart attack. What about obstructive sleep apnea? If I could do a poll on this, I bet you would not get anywhere near a guess that even for mild apnea, it's 23 times more likely to have a heart attack. So the question that came up is, is it related to anything cardiovascular? You can about rest assured apnea is going to make you more prone to it. And it certainly may not have be the only thing that killed the judge, but it certainly contributed to it. And it contributes to all the things on the screen here. I think that was one of the questions that came up. So everything on this screen is independently associated with untreated obstructive sleep apnea, maybe with the exception of cancer. Cancer is associated with oxygen desaturations. Now, we've got studies that show that. And so if you have apnea, most of the time you do desaturate below 90. So other than that one, everything on here, do you want this stuff? And would you wear a mouth guard? Would you put in a piece of acrylic like this in your mouth, or even a CPAP, to prevent all this stuff on your screen? And I think most of us would say, yeah, we think breathing is kind of important. So let's have a discussion about what my options here are. And so why do we do this?
And Guy, let me interrupt you.
Sure.
Sometimes it's that simple.
Yep.
So I'm going to, what you just said there kind of went right over the top.
Good point.
But sometimes it's that simple. Look here. Now look at all this stuff. You can just put that on your letterhead, put it on your wall, and just when you go, people go, holy cow, man, I've got like 5 of those things, well, you probably have sleep apnea too. We need to talk about getting you tested. Sometimes it really is that simple. So some of these are little tips that you can do as you get involved in this, because I think what happens, Guy, with most dentists is, and again, I think this goes back to our education. When you go to medical school, they throw you into the emergency room, and they go, hey, save this guy's life. In dental school, they go, hey, here, we'll let you practice on plastic teeth. If you're really good, we'll let you practice on a dead guy's tooth, and eventually you get up to a real person, I think part of that has to do with our tolerance for how we do things. So often dentists want to learn everything about something before they do it. Right. And I love to say, fake it till you make it. But part of this is you just need to jump in and do this. You don't get in over your head, but, team up with somebody. Do it right. I'm not saying don't do it right, but part of this is you just have to do it. If you can learn how to do a root canal, trust me, you can learn how to do this.
Absolutely. I like what you said there. So sometimes it's that easy. I'm going to change that even a little bit. I will just say it can be that easy. It's up to you to make it that easy. If you believe this,
don't overthink it. Don't overcomplicate it.
Don't overthink it. If you believe it's my job to do this, and I'm supposed to be looking at the airway, don't most people want to breathe? Don't most people not want this stuff? And if you just get out of your own way and just go in and say, hey, you got to do something about this, Mr. Jones. I've known you for 5 years, and I see you at church or the golf course or whatever, and I want to keep seeing you there. Let's go get this done. They'll do it. They'll absolutely do it if you get out of your own way. So it's not that it can be that easy. You can make it that easy if you just adopt the right attitude here. And we harp on that a bit because we train thousands of dentists how to do this. That's what we do our whole other business. That's all we do is train dentists how to do this. I've been a consultant. I've been in their offices. I get on the phone with them every day. And until you believe it's your job to do this, you'll have a hard time with it. You'll start thinking, I'm just trying to sell someone the newest Invisalign thing. This isn't straightening teeth, folks. This is important. It's breathing, it's sleeping, it's health, and it's your job to do it. And it's the right thing to do too. If you do this for your patients, they're ultimately going to thank you for it once you get involved in doing this. So we went the first 30 minutes or so here kind of talking about, you know, what apnea is and why dentists should be involved, and why it's really a breathing problem and not necessarily a sleeping problem, even though it does affect the sleep. Let's talk about, for the next 30 minutes or so here, Rich, and we'll be finished in the hour and have time for any questions, is how you do this in your practice. And that's kind of what we specialize in, is helping you put all these moving parts together. There's nothing difficult about each step of dental sleep. I like to say it, and I hope this comes across right, that it's not difficult, it's complex. There's like a lot of pieces, and it's like a little puzzle to put together, and you got to have systems for each of those little parts, but none of the parts are difficult compared to doing a root canal, as you said. And we're going to break these down into the four biggest parts, which are screening, testing, treating, and billing, and then some sub parts about systems and so forth that you need to do in your practice. So if you want to do this and you come back and you say, I'm not really doing what I need to do, come back to the slide and think, what am I not doing here? Am I screening my patients? Because if you think I don't have any patients, 1 in 5 of them has this problem. If you have 1,000 adults, you have 200 patients or more who have apnea. You probably have 500 who snore, because about half or more snore, and those can be helped with a dental device too. So you've got to get these systems in place. So Rich, you can just jump in. I'm sorry, I get on a roll sometimes. You have anything more to add on that?
You know, one of our DS3 members, John Bowes, you know, one of the things that he says that I told him I'm going to steal from him, and here I publicly admit that I got this from John, but he says, you know, every day at the end of the day, I think, man, why in the world am I doing this? That's because part of this can be challenging. And then he said, the next day I wake up and I come in the office and I remember why I'm doing it when the first patient comes in. And I look at how much better they look, or how they feel, and how I'm, you know, they're off blood pressure medication. They're starting to lose weight. You know, we're really changing their lives. So I think that's a good way to look at it. You know, so if you break this up into what we call our 4 pillars there, you got to have a system for how you screen this. Who in your office is responsible for that? How do you do it? We want to get people sleep tested. Again, we could talk about each one of these for a couple hours. Right. We're just hitting the high spots here, you know, and then we got to, because, you know, if everybody in the U.S. Who needed a sleep test, we couldn't do them, Guy, in 5 years. There aren't enough sleep tests out there to do that. And we certainly couldn't make half of them a dental device. So I think probably half of the patients out there would end up with a dental device if every patient were given an option on what they preferred and what we did. You know, I taught a course with Craig Schwimmer out of Dallas, an ENT, who does the pillar procedure a lot. And he told me 20 years ago, Guy, he said, Rich, I don't care what it is. When it comes to sleep apnea, it works about half the time, you know? So when we look at how many dental devices we make in my office, you know, some people won't wear them because it hurts their jaw. They won't get over that hump, you know? Everything's different, and there's a challenge there, but I like what you said, Guy, about that particular slide. Just look at this and say, what am I doing right? You know, what do we need to improve on? You know, what kind of system? And again, you don't have to reinvent the wheel. There are people out there. When Guy and I started this, you know, back when GV Black was still around, we were, you know, it was a little more difficult, and it's not as hard now. So how do we find these people? Yeah,
we're going to give you just some overview of each of those pillars just briefly. Again, we only have an hour. We'll talk about where to go from here in a minute. But if you want to screen your patients, if you'll just start with asking these 3 questions. Do you snore? Do you have daytime sleepiness? You can use something called the Epworth Sleepiness Scale for that if you like. And hypertension. You probably already have the hypertension on their medical chart. And if you just go think we're crazy, this bunch of old guys have been talking about sleep so long they're nuts, go back and ask your 3 patients these 3 questions. I'll bet you'll have a stack of people in a week or 2 that say yes to one of those, and you'll have just about as big a stack that says yes to 2 or more of these. And when you realize that the need there, then you come up with a way to discuss each of these red flags as we're going to go through, and a way to put people who are in high risk in a category to sit down and have a discussion with them, you're going to find that we're right. And I think, that we're always kind of playing catch up with the statistics, and I believe that it's pushing 1 in 4, especially when you look at the obesity rates in our country, and that, most people who are obese have this problem. And, if you just put that formula together, it's pushing 1 in 4 here. And this is an important slide. If you want to take a screenshot of it or get your phone out and take a picture of it, this is what you want to look for in your patients. If they have any of these red flags, and we could talk for a half hour, 45 minutes about these red flags, it should be boom. Oh, they have high blood pressure. That's something they're at risk. Doesn't mean they have apnea, but it's a risk factor. Oh, they have a big neck. Oh, that's a risk factor. Oh, they have AFib. Well, half the people have AFib, have apnea. So you start adding these up, and you're going to pretty quickly be able to say who's at risk and who isn't. You probably need a system to do that a little bit, less than just using your intuition, because you'll get kind of busy doing it. So look at different screeners that are out there. We have one that we use. We actually have one that's being tested right now. It's going to be available to anyone. They can put it on their website. But you need a quick way to say, hey, this person's at risk like this. And you need to decide who you're going to ask that questions to. Who are you going to evaluate and when? The answer is you need to evaluate all your patients' airway at some point. That's your job to do it. But you don't have to do it Monday if you haven't started doing this yet. You need to, maybe get a system in place. Start with your new patients. Start with your best hygienist, and start evaluating them. And you need a quick way to do that. With the screeners that are out there, with electronic ones like we have, paper forms, you should be able to assess someone's risk for this in no more than 10 minutes. And maybe even less than 5 minutes in many cases. Questionnaires do a very good job of this. What we did is digitize the questionnaire. It makes it a little more interactive, because when the patient looks at the screen and goes, I'm at severe risk, what does this mean? I love it when my patients ask me questions. A lot of my conversations are to get my patients to ask me questions that I already know the answers to and want to tell them. It's a lot better to kind of have it that way. So pick a system to do this. This should not be the stumbling block for you. If you're already doing medical histories, you should be able to get away to see who's at risk. And I think most people do that well. I think more people stumble on this one, probably. They get those results, the patient's at risk, and the patients aren't getting tested. That's where I think when we look at analytics and we do consulting with offices, we look like, are you screening your patients? Yeah, but no one's getting a sleep test. Why is that? Well, we've got to have the right systems in place. And Rich, our webinar we did, a couple times ago about telehealth, there are some changes that have happened since COVID, since March, that are making this barrier drop. And it's all about barriers here. When Rich and I started doing this, we can, pretend we're your parents and say, you don't know how good you've got it. When I was your age, this was the only show in town here. This was the only show in town here with the PSG. And now we have home sleep tests. We thought, well, that's going to solve everything, didn't we? Oh, everybody's going to get tested. Well, still people don't get tested. Well, what's the barrier? Well, I got to refer them to a physician. Well, now there's telehealth. And we can refer you to some people. Just contact us, and I'll give you our contact at the end, and we can help you through a computer, have a consult with a physician anywhere in the country, and have a patient mailed or delivered. You can even hand them one of these home sleep testing units, and we get them tested. Because what'd you say, Rich? There's nothing's perfect, right? So is a PSG better than an HST or vice versa? We could do a poll on that if we wanted to.
Who cares? It's like reporting the AHI at 7.2. It's like
right.
Like the 0.2 really makes a difference,
Right.
But one thing you said earlier, Guy, that we really need to, I want to say again too, is on the screening part. We talked earlier about sometimes it's that simple, but you need to stay out of the way. And then you talk about, when we look at our own analytics in Dental Sleep Solutions and DS3, and we analyze why our members have issues, a lot of that is where you said, from the screening part to the testing part. So part of that is you have to believe in what you do before you do that. That's why I said, don't wait for your spouse to die, or your best friend, or your office manager, or something like that. don't wait for that to happen before you have a why, you know, and you can do that. As you learn more about this, knowledge is power when we do that. And, you know, when I go into these offices, Guy, just like you do, and they go, man, I just can't get anybody to do a sleep test. And I'm like, there's 2 dentists in this office, and you have 4 hygienists, and each hygienist sees 8 patients a day. That's 32 patients. I showed up, I took them to lunch, I went back to their office, and I stayed for 2 hours. In 2 hours, we got 7 people to schedule sleep tests. They hadn't got a patient to do one in the last 2 weeks, you know? So part of that is in what you believe and how you do that. So, you know, a PSG is a polysomnogram. That's the in-lab test. You know, I know you like to say, Guy, it's a more accurate test. Yeah, where you go to the lab and you do that. And like you said, the good old days, you know, weren't so good, actually. You know what makes the good old days good is a poor memory, Guy. We just don't remember some of that stuff, you know, how bad it was. And a home sleep test might be slightly less accurate. I think the technology is getting better all the time with that. The point is, it doesn't matter. We're simply trying to identify people and get them in the funnel so we can treat them. So don't get hung up on that kind of stuff. And when you mentioned before too, Guy, I love it when somebody asks me a question. Now, I believe most dentists, especially new dentists who are learning this, they don't love it when somebody asks a question. You're confident and you're competent. And you love it when they ask a question because that means you know that they're interested in what you're talking about. That's the first thing they teach you, you know, when you go to car sales school. Well, what kind of gas mileage does it get? You know, I mean, that's this guy's like, oh, I got this guy, you know, because he's at least asking questions about it. And you can punt on some of those questions. You know, if you are a confident individual and you can say, you know what, I'm not really exactly sure what the answer to that is, but I know sleep apnea kills you. And I know it causes in some way all of these things. I'll find a specific answer for your question. But in the meantime, you need to get a test. Here are the options for how we do it.
Absolutely. And you need to have those options figured out. And we could talk for another hour about the options that are out there. There's more than one way to get an HST. You can work with companies, you can own your own. You can work through DS3 where you can order them and results come back into you. We can help you with all those. And right now, what's come up again since March is there's telemedicine options so that you don't have to order the test. You can work with doctors who are remote, who can help you get a diagnosis. And so you've got to have a plan for that. And so I think probably the biggest holdup for dentists is the step between screening and getting their patients tested. That's just what we've found to be. Once they break that to where they're good at that, then they can really start seeing a lot of patients, because what will happen is then they start working with physicians who recognize, because some of these people need CPAP. You start sending letters to the physicians, you start working with them, then they start sending you patients. It starts the ball rolling. So if you're not getting past the test part, then maybe it's screening, or maybe it's the test itself, maybe the way you talk about it, maybe having a good plan for that as well. And that has become so much easier that it should not be a hurdle. The out-of-pocket for a patient to do an HST, if you have no insurance, including the telemedicine visit, is around $300 on the higher end. I mean, if someone's not willing, if you can't get them to pay pay someone $300 to breathe when they're spending that on Starbucks and everything else, then we have a value problem here. Where the patient doesn't see the value in what we're doing, and we've got to find a way to get over that. So we got some more questions coming in. We'll get to all of them here in a minute about which was the best HST out there. I think we'll be happy to discuss that in a little bit. We want to touch on the other 2 pillars briefly, and then we'll open it up for any questions that anybody might have. Type them in the question box, and Rich and I'll stay on as late as probably as you need to. It's reasonable to do this. So the treating part of this,
By the way, Guy, did you see how I answered that?
No, I didn't see what you put.
The best home sleep test out there, that's the one that the patient will do.
There you go. But that's a beautiful, I'm going to write, can I write that down somewhere? That's, because all we want to do is get them tested.
Yeah.
We want to get them tested. We want to make sure we know what their airway is. And I'll even say this, if that's the biggest holdup and for some reason they're pushing back on it, then make them a dental device anyway. If they're snoring and have all these symptoms, treat their airway with something. you know, and then let's get them tested down. I have patients come in and they're resistant. Let me make you a temporary device and then we'll get you tested in a month or something. How's that? If you'll agree to try this, I'll help you with this. If you'll agree to be tested down the road, if I can prove that this thing's going to help you, just get them treated. Quit overthinking this thing. Patients care about breathing, and we can help you with these steps of dental sleep. That's what we specialize in, is helping dentists bring all the systems you need. We've talked about the screening and testing, and then there's consults you got to kind of be ready for. You got to worry about insurance and do pre-authorizations, how you do the exams, which devices you do, when you deliver the devices, how do you do that? What do you say? How do you get their jaw to go back? What do you prevent jaw problems? What do we do after we give them the test? We got to follow up with symptoms and make sure they're wearing it, and then do some follow-up testings. Then we see our patients about once a year, 6 months initially to make sure they're doing okay, then about once a year after that. Those are the steps that are in there. Is there anything terribly difficult in any of these? No. But you're going to need to have a system for that. I'm going to talk about courses that we teach virtually now that we go through each of these systems. And if you're interested in learning how to do that, you will leave that course, which is done in the evenings. I have one come up in a few weeks that will teach you how to do each of those steps in your practice. You even get a recording of the course, and so you can bring it back to your teams. As far as treating goes, you're going to need a way to manage this. If you are already doing this and are struggling with managing this, it's because you're probably using a system that was built for dental, like Dentrix or EagleSoft, which are great systems for helping you manage dental data. But this is not dental data that you're doing. It's not dental steps. You might as well you go down to your podiatrist or your I don't know, whatever. Go to your chiropractor and borrow their software to try to manage your dental sleep. It's not going to work well. You can maybe cram it into some of the things they have, but it's not going to help you. So we can talk to you about that if you want a better system for this. And then billing, we teach, I'm going to talk about a half-day course that you can attend for very reasonable here in just a few moments. We can help you with the billing. Here's the good news is medical insurances do cover these a lot of times. Sometimes they don't. I mean, they almost always cover it, but sometimes patients have bad insurance and high deductibles. But that's just money you can tap into if they have it. But let's don't go down this road where insurance dictates people breathing at night. If a patient has a $5,000 deductible, don't go, well, you got a $5,000 deductible, so I guess you just want to choke to death at night, so we'll see you later. No, you go and say, hey, you got high deductible, we need to do this anyway, let's work this out. And you need to have a cash system in place. I suggest you start that way as opposed to letting insurance bog you down. Now, the good news is once you get insurance under control and you have a system like we can teach you and like we do through DS3, where we do all the insurance, we verify the benefits, we can teach you how to do this. If they have good insurance, which a lot of people do, it's a seamless process that we can help manage for you to help you make more money per case for those patients who have good insurance and the patient to pay less. It's a win-win. But then some of the patients maybe fall into the category of fee-for-service when they don't have that benefit. I think that's one of the holdups, Rich, on the treatment part. I think we get so obsessed with the billing that if a patient doesn't have an insurance that pays for all this, then they're dead in the water.
Right.
And I think most people will pay something, and we can usually work that out with them when we believe this is extremely important to do. So those are the four pillars. I'm going to talk in a few moments about how we can teach you more about each of those. Unless, Rich, you have anything more to say, I want to do this quick survey, and then we're going to just spend the rest of the time answering questions.
I'm good. I'm typing answers, so go
All
for
right,
it.
Rich, your time to answer. So I'm going to ask everyone to do two things. I know we're running towards the end of the hour here, but I really, if you could do two things. One is please participate in this poll. And then number two is be honest with yourself and us, because I don't see who's answering these polls. And my question here, when I put this poll up, is how likely are you to get this patient to go get a sleep study? You refer them, I mean, they have an Epworth of 14, they have hypertension, they snore, they've got diabetes. If you're kind of new to this, trust me, it's a pretty, this person's got really high likelihood of having OSA. And so I'm going to ask this question here and pull the poll up. Okay. So how likely are you to get this patient to actually complete a sleep study or even go see the sleep doctor, however far that is down there. Hope everybody can see that. I launched it. And be honest and participate. I promise this will have some effect if we can have this discussion in just a moment. So we got some polls coming in. Thank you for participating. Appreciate it. And we've got, I'll wait till we get over the 4:30. We got 48% of the people doing it. I don't want to take all night.
One of the questions too, Guy, while that's going is Dr. Verma said, can you talk a little bit about upper airway resistance syndrome? So, think about your airway being a tube, and most people who snore, I like to say, well, how come you're not snoring now? Well, I'm awake, I guess, it's just like when Guy said, when you go to sleep, that airway starts to collapse, so as we think about, there are variations of how that does. An apnea is where it closes all the way, a hypopnea is part way, and then upper airway resistance is, it's enough that I'm struggling to get some air in, but I'm still getting air. So it's kind of a continuum, of all of that kind of stuff. And this is where the technology is getting better. When we look at upper airway resistance syndrome, you don't have to desaturate as far.
Right.
And some people don't have to desaturate as much before they have symptoms. So there's never been a correlation between disease severity and symptom severity. So you can have severe sleep apnea and not be tired or sleepy or anything. Those are the guys usually die of heart attacks in their 40s and 50s.
The way I heard that described once too, Rich, is that people have upper airways. They have they're more of a quick trigger. I get a little bit of resistance and boy, I can't deal with that. So I'm going to not sleep well. So I don't desaturate, but they don't sleep well. And then after a while, we get so used to it, our bodies allow us to go down more. So great question. We can talk about that for hours as well. This poll, so what's the average? The average, the highest numbers in orange here. So the likelihood, we got 25. I'd say that you add these two together, it's less than 50% on average that we'd get that patient to go. Pretty common. We got some people down here at 95, but there's more than half that wouldn't, and certainly well more than half that are under like 70% here. So I'll take this off for a second. And now I'm going to ask a similar question about this patient. I want you to be honest. I want you to participate if you can. This patient presents to you, a 50-year-old male, smokes, and is a fisherman here in Florida. You see this upon your exam, one of these two, pick whichever one you want. I think we'd all assume that patient probably should go see an oral surgeon. So how likely are you to get this patient to go see an oral surgeon or to do a biopsy if you do those in your own offices? So it's a similar question. And I think we had about half of the people respond. So I'll stop it around. We got more people responding on this one. So that's good enough. We got 34, 50, 60, 70% now. I'll end that and I'll share the results. Does anybody notice anything different besides me? Okay, way more than 95. I mean, way more, almost, well over 80, almost everyone. And so that's the difference. I'm going to shut this down so you can see it, but we're looking at the differences, less than 50% chance for HST and well over a 80% chance for this patient here. And I don't want to throw this back on everybody that's on here because it's not the way we're coming across. We even had someone type in, I've been struggling with this, I believe in this and I'm trying to get this going. You've got to believe in this and you have to have systems in place. And when I ask this question live, we do the virtual courses. We do this in meeting format. So everybody's got cameras. We can talk back and forth. If you decide to come to one of our virtual courses, we limit it to about 30 attendees so that we can have interaction. When I ask people why so many more people say this, the things that come up, Rich, because you haven't been on those meetings lately, somebody might say, well, you can see this, and I give you that. Other people say, well, it's cancer. And I say, well, is that more likely to kill someone or is breathing more important? Well, you're right there. Why is it? And if we have a discussion with a small group about this, it really comes down to maybe the visual part's part of it, but is this our job, the tongue? Yes. Okay. It comes down to us believing that this is our job, that we have to talk to this patient. And if we don't, my God, that could be a patient that's not going to wake up the next day. And how am I going to feel then? And once we believe it's our job to do this, well, then you see the light. And everything else becomes easier because once it's a part of your value system where I'm not going to let that person leave because shame on me, because that's significant and that's serious. And if I've got to talk to this, if I fail to convince that patient to get a sleep test, I am failing that patient. I'm not doing my job well enough because I'm not convincing them to do something that's really in their best interest. And once you feel that way and you can radiate that out to your team, all the systems we can help you with, and you can go through. But until then, we really, it's going to struggle for some people. And I think more and more people are starting to feel this, and we realize it is our job to do it. And you shouldn't do it for this reason. I almost hesitate to even put the slide in here because you should do it because it's the right thing to do. But man, there is not a single thing you can do as a dentist, in my opinion, and I'm not having anybody argue to the contrary about this. As a general dentist, there's not a more profitable thing that you can do than dental sleep in your practice, because you can delegate the majority of it. And as a dentist, you can't delegate most everything else you do. If you did one device a week and took 4 weeks off, you'd be pushing 100 grand that you'd bring in with very conservative collections, including paying a lab bill, including paying third-party bill, even including paying us. If you only did one a week, you're still pushing 20 grand to do this. It's the most profitable thing you can bring into your practice. And I hope that's not the reasons that you're doing it. We're going to stay on and answer your questions. I would say
that was one a month and 20 grand, Guy. You got in such a hurry there. I want to.
Did I say something wrong?
You said one a week. You're even.
One a week's here at 100 grand. Sorry, it's one a month, 12 a year. Thank you, sir.
Not that that's important, but we all have to make a living. We get that. And, we're not exactly sure what's going to happen with this virus and that kind of stuff. So again, Guy says that because he's a good human being and he doesn't want you to be motivated to do this just by the money. We want you to think, hey, this is the right thing to do for my patient. It is difficult. It is hard because you can't see it, because you didn't have this in dental school. You didn't have this beat into your head. Most people say, Guy, it takes 15 to 30 years to change the medical paradigm. Well, what year of that where are we in that process in sleep medicine? You're right. We may be about year 15 because we're starting to see it change now. And sleep apnea is not going away.
No.
If anything, it's getting worse because we continue to eat. And, that's why Guy and I started Dental Sleep Solutions and what we do. We do these things for free. We've given away more free education than probably all the other dental sleep educators in the history of the United States. And it's because we want you to get involved in this and do this. And we have our virtual courses now. If you've not heard Guy teach this, he's fantastic and you should do it. I can't believe how cheap you guys do these for. Myself, Guy, it's the, but tell us a little bit about them. I know you've been doing
they're 10 hours. If they're 7 to 9 typically is our next one. Tuesday, Wednesday, Thursday is when this next one is. They're $495. We do offer the early bird special this week, so $200 off, $295. That includes me going through all the steps, and it also includes the 4 hours of billing course. So that's where you get the 10 hours. That is done on September 18th. So to go back, it's the 22nd through the 25th, and a 7 to 9 done through Zoom, but different format. It's the meeting format, so we can see each other. You can unmute yourself. You can ask questions. It's very much like being in the classroom together. And then again, the billing is, if you can't make the billing date, it's from 11 Eastern to 3 Eastern. Lisa, 20-something years worth of billing experience will teach that. You can watch the recording, and you get a recording of each of these, both mine and Lisa's course for a period of time afterwards. And in addition, you get a kit that's worth more than we're charging, a dental sleep starter kit. You get a MyTap in there. That alone I know is about $100. It's a provisional device. We're going to teach you how to make that so you can get started. Some brochures, a sample EMA device, some forms, pretty much what you need to get going in your practice. Again, if you are interested in that, you got to do it this week. Just type in early bird. You can type it into the chat or the questions, and someone will reach out to you. And if you want to just go to the billing, you can type in DS3 100 for the billing. I get 100 off that. It's $249 is the normal cost. It's $100 off, so it'll be $149 if you just want to do the billing. Again, if you do the virtual course, the whole that's included. If you want to just know more about what we do, that's what the slide's about. We help you through education, coaching, software, and support. That's all we do. If you want to if I saw a lot of questions you answered there, Rich, if you want to know more about those, just type in consult. And one of our team, we have a whole team of dental sleep medicine experts. That's all they do is train dentists doing this every day. Just type in consult and someone will reach out to you, set up a time, answer your questions, tell you how, first of all, answer the questions, help you whatever challenge it is, whether it's screening, testing, treating, or billing, we can help you. And then we can also talk about how we can continually help you as well. So there's those again. And if you want to just get our next webinar, forgot it, almost got ahead of myself, and we'll talk about getting your CE in just a second, so hang in there. I'm excited to have our good friend John Tucker who's going to be with us. We're going to talk about the building blocks. So what do you need as a foundation for bringing dental sleep? So it'll be Rich, myself, and Dr. John Tucker, who's we've known for quite a few years. I'm really excited about this because it's going to be kind of a little bit more of an open dialogue, and we've got some 8 or 10 building blocks we're going to talk about to really get a good foundation for your dental sleep practice. So same time, 8 o'clock Eastern, on September 29th. Housekeeping, if you're going to get CE for this, it'll come to the inbox that you, whatever email you registered with, it should be there within 48 hours. If for some reason you don't see your CE certificate, check your spam folder. And then if you don't find it, by all means, feel free to contact us. Here's how you can get a hold of us. If you want to register for the course, somehow my slide automatically advanced. There's another, there it is again. Just type in discount or course and someone will reach out to you to make sure you get set up for that. And I promise you, you'll leave there going, wow, this was great. We've got a lot of very valuable information. So Rich, is there more questions? If anybody else has any more questions, type them in the
I think we got to a couple of them. One touched on TMJ, and I said, it's just not amenable to this type of thing. I know when Guy does his course, he'll talk a little bit about that. And, you can certainly, when I learned how to do this 20 years ago, Guy, hey, they got TMJ, let's stay away from them. And we've almost come 180 degrees for that. I truly believe I could probably treat as many patients successfully with a dental sleep device, TMJ patients, as you can with certain types of splints. And we incorporate some of those splint designs into the dental devices themselves. So, don't think that you can't do that. As you learn more about this and you do that, what would you say, Guy? Here's a question for you. What is the question that you get asked most often by dentists, about this? Which dental device should I make them, or what?
You were cutting out a little bit. I don't know if it's my internet. Maybe
I don't know.
It is. We're getting a storm here. Someone's mentioned that I didn't stop sharing the poll, so you probably couldn't see the slides, so I'm going back through them. What are you asking? What's the most common question I get?
Yeah, what a dentist asks, so there are a lot of dentists out there on tonight, and they're thinking, oh, wow, that's a stupid question. I shouldn't ask that. And there are no stupid questions. But give us a couple of those.
I think that one of the most common questions is the least, one of the most common, and I'll tell you, is probably the least important. Which device do you do where? Right. When? I think we're going to go through the devices you use, when you might use one versus other. And I could just give you the sneak peek there. Most devices work on most people, but we're going to tell you which ones are better to be making on certain people. Other things that come up a lot are really a lot about HSTs, home sleep testing. How do I do that in my practice? There's a lot of different ways you can do that. And we'll address, the various routes you can do, whether owning your own equipment, working with companies, working with your local doctor. So getting that system in place. And I think where people struggle the most after they get past the screening and testing is, what do I do once I hand this device to someone? What's next? And that I can tell you, even if you've been doing this for many years, it's worth coming to the course because we're going to teach you a very efficient way of doing that. I used to spend an hour and a half to 2 hours of my time handing people sleep testing. And we have a way now that I spend less than about a half hour or less with my patients total treatment. We'll tell you 45 minutes should be a good goal. And where we've really saved the time is on that titration. What do we do once we hand them the device? And we've got a way of doing that that's predictable, that's efficient, and it's really user-friendly for the patient. It's not real costly to you or the patient either. Some really new stuff about that. So those are, I would say, some of the real common, and where to take the bite. You know, how do I know where to take the bite? Everybody's stressed out about that, but if you use a good follow-up like we're going to talk about, then where we take the bite's really not even that important either, because we're going to titrate them or calibrate them forward in a very efficient manner over just a few nights with an inexpensive measuring devices that we'll talk about.
Yeah, and you know, stay tuned for that. You know, we want to dangle that carrot out there in front of you a little bit, but the way that we're doing telemedicine now, and the way that we're doing home sleep testing on both the front end and the back end for titrating our dental devices has really, really changed in the last year. I mean, Guy and I both truly believe that this is the biggest game changer, you know, ever. And what we're talking about doing is not way out in left field. The bar's still up here. We're still doing it that way. We're still doing it the way the AADSM, you know, wants us to do this kind of stuff and all that other stuff. But, you know, we've also got to figure out a way to get more of these people in the funnel. And that comes from you dentists out there. That comes from you dentists doing the screening. That's why Guy, when he puts these PowerPoints together, you did a great job, by the way, Guy, of that, as always.
Well,
you know,
I've got to point out one thing here. So anybody who knows me knows one of my biggest faults is I'm a terrible speller. And Steve, our marketing director, is better than me, but only by this amount. I'm from Kentucky originally, so you know English is a second language. So, but it's early bird. But if you type in Erie bird, we'll still give you the discount here. So someone just pointed that out. I think it was Michael or someone pointed that out.
I didn't even see that.
I didn't either, so I didn't catch that. So we'll accept either one. If for some reason it doesn't work as a discount code, contact us for the $200. And Steve asked me to look it over, but he should know better than to have me me proofreading anything. So not one of my talents, unfortunately. So but anyway,
well, thanks again, Guy, for putting that together. Thank you for our staff who was taking part of their evening as well to help with the questions and all of that. We appreciate you guys sharing part of your evening with us, and we certainly hope to see you in a few weeks on the 29th.
On the 29th, and I'll put this back up since apparently the contact information was hid by the poll a minute ago. So there we go. That's how you get a hold of us. Info at dentalsleepsolutions.com. If you want anything more after this, you can always get a hold of us then. And if you want to watch this video, by the way, we do post them on YouTube as well. So if you want your team to see it or something, it should be up there within a week or so as well. So you're welcome to watch that for free. And thank you for joining us. I think the meeting with Dr. Tucker is going to be great next week, next few weeks coming up. And I don't see any more questions. So I guess we can go, Rich.
We're good. Everybody have a good evening.
All right. Thanks.